about to present is Dr. Mohamed Fakih from the Pediatrics Department at Jacobi Medical Center of Mount Sinai, affiliated with NYC Health. Alumni of the Wayne State University School of Medicine.
Thank you. Thank you so much. I'm happy to be here. I'll be presenting on a case on when an overuse injury isn't a diagnosis. Patient here, a 12-year-old patient, right-handed dominant boy. He presents with a 1-week history of right elbow pain. He plays as a pitcher and catcher. He also, his father is an avid sports fan and wants him to go to the MLB to pitch. So he's been, over the last few months, he's been pitching 80+ pitches per day. He has a high fastball at 85 miles per hour. He's been endorsing this history of right elbow pain. Denies any trauma at all, but he endorses that his pain is worse while throwing. And the only sort of improvement is with the rest. He also endorses sometimes there's pain in the elbow, but he does not have any recent illnesses, fever, chill, cough, congestion, or any other sick context surrounding him. Just so note, this is 1-week history of right elbow pain. Going on now to the physical exam, I'll show you his medical history. So he has no pertinent medical history, no surgeries, no medications, no known allergies. He has no family knee, elbow, or any bone disorders in the family. So based on this setup in this picture, one of the first things that comes to mind to me is, does he have an overuse injury? And if you look at it in his clinical scenario, going back to his presentation, he's been pitching for over 80 pitches per day. He has a high fastball. He's only 12 years old. And someone like this, one of the first things that comes to mind to me is he overusing himself? Is he overextending and pitching? Especially that he has pain while throwing and improves with rest. But it's the motivation of his father to get him to the MLB, and he's like, pitch, 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 continue to pitch. So this is one of the first things that comes to mind to me. But the one thing that alarms me also is there's pain in the elbow at night. I'm not sure what to make of that, but he has no recent fevers or illnesses that would, I would suspect, a more systemic system outside of that. So my first inkling in this scenario is to think overuse injury. And that's just my first thinking based on my presentation here. Anytime we have someone with injury or concern for elbow pain, the first thing we need to do is get radiographic imaging. So that would be a plain X-ray film, and that's what we did in this patient here. Prior to that, actually, I'm just going to go over some labs. This patient is afebrile. He has a temperature of 99 degrees, heart rate 95, blood pressure 103/68. Saturating on 99% room air. Because of this pain here, we also can incorporate some labs. You got a white blood cell count of 7, hemoglobin hematocrit of 12/40, and a platelet count of 240, all within normal limits. His CRP was 0.8. Just to give context, anything below 1 is normal. Also, another inflammatory marker that we look at is an ESR, which was 6, so it's within normal range. So based on our vitals and labs here, patient doesn't have a fever, doesn't have a high heart rate, normal blood pressure, and relatively normal labs, nothing significant out of the gate. Next thing we look at is the physical exam. We notice that there's a right elbow pain. It's not erythematous, but there's some swelling. He has some with the active passive range of motion. It's a little affected in the affected right elbow, but the left one is unaffected. He does have some tenderness in the lateral aspect of his elbow, but he has good strength both bilateral elbows. Only thing pertinent is some tenderness of palpation on the lateral aspect of the elbow. Based on this, we get a differential diagnosis. As I mentioned beforehand, one of the first things we want to look at is little league elbow. So medial epicondyle apophysitis or ulnar collateral ligament sprain. But because of the significance of the pain, we also can't rule out any fractures. So a lateral condyle fracture, a supracondylar fracture, or an avulsion fracture. And as I said before, something in the back of my mind is this a potential tumor? Very unlikely in this case for a 12-year-old, but I did mention here chondroblastomas, osteoblastomas, or benign tumors. And then malignant tumors are like immune sarcoma, lymphoma, as well as an osteosarcoma or distant metastases. As I mentioned beforehand, the first thing we would want to do in this case is get some radiographic film. So we did. We got an X-ray film. And look at here, we have a both lateral and a frontal view. And the initial report, as you can mention, look at there's swelling at the near the elbow joint, near the diaphysis and epiphysis, as well as some swelling. And they mentioned that you can look here in the lateral film, there's some cortical destruction, the proximal radius, along with an associated soft tissue mass in the proxiform. Now, this one threw me off initially when this imaging came across, because my initial instinct is to think of an overuse injury. However, in this 12-year-old who's grown fast with this acute onset of pain, the less likely thing on our diagnosis is a tumor. But based on our findings, there's a suspicion for a potential tumor, given that there's mass swelling as well as cortical destruction of the proximal radius. Next thing you would do in a workup would be to get some MRI imaging. So based on our workup here in initial imaging, we got an MRI. And I was able to find an MRI of a different long bone that demonstrated an osteosarcoma tumor. So here's actually, just to give a backtrack a little bit, we have a X-ray film of a distal femur. And as you can see here in the AP and lateral views, it's a pathologic fracture, significant cortical destruction here. And this is one of the things, as I mentioned before, we think in our back of our mind, is we do not want to have a tumor of the bone tumor. In this case, in a different patient, they presented with very similar findings, and they were ended up having a pathological femur fracture, both looking here in the AP and lateral view. In this scenario, the next sort of imaging we'll be obtaining will be an MRI. Here, I have another patient case here of a MRI of the femur. And this MRI, both in the sagittal and the axial view, demonstrated a large soft tissue lesion at the medial aspect of the femur of the diaphysis, some cortical erosions and primitive infiltration. It shows some kind of post-contrast enhancement. In layman's words, is this demonstrated a tumor in the medial aspect of the femur, and through this imaging, we were able to get a biopsy found that, and it demonstrated an osteosarcoma by some biopsy. So these are things that we do not want to miss in a patient that comes in with either elbow pain or acute onset of knee pain or leg pain. These things are not very common, but these tumors are easily treatable. And as I'll talk about later on in this case study, can be treated with multimodal treatment. So, as I mentioned before, in our prior case, the concerning diagnosis for the previous case study was an osteosarcoma. I want to go over what that is. So, an osteosarcoma is a cancerous bone tumor, and it mostly happens in the arms and legs, but can affect other bones. In terms of signs and symptoms, very similar to like an overuse injury, it causes pain in the bones, which worsens with exercise, and can sometimes occur at night. As I mentioned beforehand, pain at night was an alarming symptom that's not typically common in an overuse injury, but something that you want to be alarmed about. It also has a lump or swelling in that area that forms. And like overuse injuries, these typically develop during adolescent growth spurt. Our patient was about 12 and a half years old, right around the growth spurt. And typically osteosarcomas occur between the ages of 13 to 16 in boys, and can occur a little bit younger in girls. But there is a predilection for males. It's a 1 to 1.4 to 1, slightly dominance for males over females that present with osteosarcomas. In terms of the kind of physiology of it, it happens when bone cells called osteoblasts start to grow abnormally. And it most occurs at frequent sites where they're the greatest bone length and size, which means the metaphyseal portions of the femurs, the proximal tibia, or the proximal humerus, as we saw in the previous cases. So essentially what it is just an overgrowth of bone. Risk factors that can occur include prior radiation, and sometimes some genetic conditions here like retinoblastoma, Lee-Froman syndrome, where kids may develop other types of cancer as well. Now, how do we diagnose this? The diagnosis is through imaging. So X-rays are the first modality we use. followed by an MRI or CT scan of the bone if we're suspecting any tumors. We can also do blood tests, such as alkaline phosphatase and LDH. Those are markers that are shown to be elevated in patients that have a high rate of bone turnover or bone formation. And lastly, we need a biopsy of the tumor to identify and differentiate what type of tumor it is. So how is it treated? So it's treated with multimodal therapy, as I said before, with orthopedic surgeons and pediatric oncologists. They work together to treat this. The first set of treatment is chemotherapy that shrinks the tumors and kills the cancer cells, then followed by surgery. And then the remaining any remaining cells is chemotherapy. After that, to help the kids to recover, you do physical therapy to strengthen them up beyond surgery. Now going over a more common pathology, the overuse injuries, Little League elbow. Its name used to describe a group of elbow problems that related to stress and throwing in children and young adolescents. You'll hear that there be multiple different pathologies. The most common are the following: medial condyle apophysitis, which just means medial elbow pain. It typically occur in skeletal immature children, so those that are growing through puberty. A medial epicondyle avulsion fracture, or an ulnar collateral ligament sprain. If you ever heard of it, where there's Tommy John surgery, those pitchers in the MLB that are overthrowing, they may have what we call ulnar collateral ligament sprain, or they may actually tear that collateral ligament and end up being surgery. Now, how do we diagnose it? It's most often clinically. They may have medial elbow pain, initially after throwing, but then it progresses to persistent pain. Their exam, when you palpate the medial epicondyle, it'll be exacerbated by pain, oftentimes with wrist flexion. Now, what are the risk factors for developing Little League elbow? As I mentioned before in a prior case, the patient had many of these risk factors. They were throwing frequently, throwing 80 plus pitches per day or often at appearance. They were pitching more than 8 months per year, and they may have a fastball greater than 85 miles per hour. And lastly, if they're a pitcher or catcher or someone who throws frequently, those are all risk factors for developing the Little League elbow. In our patient case study beforehand, he had almost all 5 of these. So that's why my inkling for Little League elbow was very high, my suspicion. But that pain at the nighttime, I want to reiterate, something I wanted you to think about. When there's persistent pain like that, you have to think outside the box. Now looking at diagnosis, we have an X-ray here. I have it here showing you a picture demonstrating a normal elbow versus a not abnormal elbow. As you look on the left, the right elbow, there's widening of that little joint space there, that epiphysis. That's the first sign on top of the clinical findings of tenderness at that site that demonstrate there's potential Little League elbow. If you look at the contralateral side, there is no widening there. So that's the first thing we need to do. Let's get an X-ray. Now, in terms of treatment, the treatment regimen, as by one of my colleagues and one of my mentors, Dr. Eric Small, took this out of his page. He's out of Mount Sinai. He demonstrated that there should be no throwing for 4 to 6 weeks, followed by physical therapy and rehabilitation. In addition to that, you got to figure out what the root of the cause the problem is. So you need biomechanical analysis, aka you need to analyze the pitcher's throwing motion and mechanics. Are they overexerting themselves? Is there improper footing? Are there any weaknesses in their lower gait that they're overcompensating for? Or you also examine the history as well too. Is there a father in the background? They have aspirations to go to the MLB and they're overexerting themselves. Those are all things we need to take a look at consideration when considering someone with Little League elbow. Then we gradually return to throwing and pitching, along with lower body and core conditioning. Oftentimes these kids, like I said before, maybe overexerting themselves. They have weaknesses in their lower extremity. And as a result of that, we need to strengthen their core and their lower body and put less stress on that ulnar collateral ligament. And as a result of that, it may prevent future pain in that medial elbow. Now here I have a little pitch count by age. This is about by Dr. Eric Small out of his lecture. He's been treating Little League elbow for over 20 years now. And as you can see, the daily pitch count goes up as you go up. It goes up as they grow older. And in this case, the patient here is about 11 to 12 years old. So his daily max pitch should be about 85. So he's pitching at his max. But as you can see, on day 0, 1, 2, 3, and 4, post that time, he shouldn't be pitching more than 20 to 35 and gradually increasing his pitches. This patient of ours in the case was continuously pitching 80 plus pitches per day. And as a result of that, he's putting a lot of strain on the ulnar collateral ligament, increasing his risk for outlining elbow. And as you get older, you can see as a 7 to 8-year-old, they should begin about 50 pitches per day max. 9 to 10, 75, 11 to 12, 85. And as they get to 13, 14, a max of 95 with the gradual progression to increase their pitches with rest. So one thing I want to mention here based on this is the importance of rest following pitching. It's very important for someone who's developing and is skeletally mature that they need rest and time to recover so that they don't overuse, overextend their ligaments and muscles. And then here I have a picture from his lecture in terms of the interval throwing program. So as you can see, this is over a period of time, a gradual return back to the pitching scheme. It's about 3 to 5 times per week. And in their first week, you start with 30, pitching from 30 feet away, 45 feet, and 60 feet. As you get more and more at weeks 3 and 4, it's 45, 60, and 90. And at weeks 5 and 6, it's 45 feet, 60 feet, 90 feet, and 120 feet. It's about 10 to 15 pitches per distance. And you start about 50% effort and gradually increase your effort as you go along in the progression of the program. This is something that he's devised. It's not been scientifically studied, but it's a program that he uses, Dr. Small, and as you can see in the bottom right with his 2 sons. He's devised this program here that has helped pitchers that he's treating literally elbow gradually return back to sport. I just want to end this talk before I conclude with some take-home points. All skeletally mature patients that are going through puberty, adolescent, or throwing with elbow pain should receive radiographic imaging. It's imperative to do that because the one thing we do not want to miss is cancer. And then the second thing I want to mention is not all types of cancer may present with fever, weight loss, or chills. These are systemic symptoms that are often associated with cancers, but in osteosarcoma, it does not always present. And then the third point I want to make is always keep cancer in the back of your mind. We got to think outside the box. If a patient comes in with a prolonged course of symptoms and doesn't fit the picture, we always got to think of what's something that I'm not thinking about. Next, I want to mention that more pitching isn't better for young athletes that are still growing. Rest is extremely important for their developing body and their ever-growing body. So these are the things that I want to be impressed on to you guys and impressed on others that are listening, that these things are things we need to consider when a patient comes with an elbow pain or any sort of pathology. And with that, I am going to conclude my talk and open the floor for any questions.
Hello, Dr. Fakih. By the way, excellent presentation and very fascinating case, by the way. I just have a question about osteosarcoma. So do you usually see that osteosarcoma growth in long bones, or are there any other bones that are equally as susceptible, or do you usually see it in long bones rather than other bones such as short bones, flat bones, and irregular bones?
It's primarily long bones. So the pathophysiology behind it is there's an overgrowth of the osteoblasts. So it's primarily found in areas where there's a lot of development. So your femur, your humerus, where there's a lot of potential for growth. And that's the risk factor, or that's the underlying pathophysiology. It's not completely well known why, but those are just common theories that are being done. So it's not very common in short bones just because of the natural progression of the overgrowth of the bone cells.
Great.
Great question.
I just wanted to ask another question.
Of course.
So especially on that slide where it was mentioning like potential fixes for the injury, mentioning like weak lower extremities or bad biomechanics or stuff like that. I was just wondering, like, like for like a patient that comes in with something like, and then they have to think about biomechanics, they have to think about muscle weaknesses, they have to think about resting appropriately, like following like a specific training regimen. Like I feel like if I was in the place of the patient coming in and then I had like elbow pain and that was what they told me, like I would be kind of overwhelmed. Like so many different things to focus on. Like, so generally, like, would you recommend like doing one at a time, or like would it just be good to like try all of those like different treatment methods like at the same time, or like what, how do you usually like recommend treatment methods?
So the treatment method typically, so you want to first understand what the source of the problem is. The first thing is rest, and then at the same time, while you're asking questions about how they're throwing, how many pitches per day are they doing, what other sports are they playing, are they playing multiple injuries? So I think it's in total part of the package of the history taking that you take when someone comes in with elbow pain and they're in the adolescent age group. Those are things you're going to ask for as just part of your workup with the patient. Just taking a very thorough history. The rest and the other aspects of the strength training will be part of your action plan after you get the kind of diagnosis based on your clinical suspicion. So first thing first, taking a good history, good questions on their throwing motion, how often they do it, and those are imperative things. And then you go to the treatment plan afterwards.
Okay, thank you.
No problem.
One question, Dr. Fakim. About like the age, is there any treatments or any ways to anything that is not allowed due to the person's age? And as you're examining people who are older with experiencing cancer in their bones, do you believe that there's some other ways, treatment or other factors that can lead to this?
Yeah, so radiation, chemotherapy, increase the risk for it. Those are things we got to take into consideration. So a good history. And then those are the biggest two risk factors for it. And then there's also genetics. So if there's a genetics running in the family, that's another risk factor to look for to predisposes them to potentially developing osteosarcoma or any bone tumor.
Thank you.
So on that note, I wanted to just say, so I guess to bring it around to this presentation, what are some of the complications that you think you would encounter hypothetically in this young, athletic, adolescent population, a complication with this?
The big thing we're about is a pathologic fracture, but also distant metastases. So if you were to not miss this and the patient comes in and they continue to overuse it, they may see the tumor to elsewhere into the bloodstream, and it can lead to metastasis of the disease if you don't catch